Assalamu alaikum. Welcome all to the Human Anatomy channel. In this video, I discuss pleura, anatomy, developmental anatomy, and clinical anatomy. At first, the definition. The pleura is a double-layer serous membrane that inverts both lung, lies on either side of the mediastinum within the chest cavity. This is lung, this is visceral pleura, and this is parietal pleura. The parietal pleura line inner surface of the thoracic case, upper surface of the D diaphragm, mediastinum, and extend into the root of the neck. The visceral pleura completely cover the outer surface of the lung and extend into the depth of the interlobular fissure. This is oblique fissure, this is horizontal fissure, and here the visceral pleura is present, but parietal pleura is not present in this surface. Parietal pleura again divided into costal pleura, diaphragmatic pleura, mediastinal pleura, and cervical pleura. This is pleural space present in between visceral pleura and parietal pleura. It contains small amount of fluid, 10 to 20 ml. More than 20 ml fluid can be detected by ultrasonography. The function of the pleural fluid, it acts as a lubricant. During inspiration, it allows easy glides of visceral and parietal pleura over each other. It helps maintain negative pressure in pleural space, which is necessary for the normal lung expansion. Costal pleura lines the inner surface of the thoracic cavity, ribs, and firmly attached to the endothoracic fascia and periosteum of the rib. Diaphragmatic pleura cover upper surface of the diaphragm continuous with the costal pleura and make costodiaphragmatic recess. Mediastinal pleura cover the lateral surface of the mediastinal structure like pericardium, descending thoracic aorta, esophagus. At the junction of the costal pleura and mediastinal pleura, here the costomediastinal recess is present. The left costomediastinal recess is large due to the presence of cardiac notch. Cervical pleura extend up to the neck above the level of the thoracic inlet. This is thoracic inlet and this is the cervical pleura. Cervical pleura is covered by the Simpson fascia. It prevents the lung apex from the herniate into the neck, but a defect in this structure can allow the lung to protrude upward, leading into a swelling in the neck, especially during coughing. Now to confusing term, discuss root of the lung versus hilum of the lung. Root of the lung actually is the area where the structure that connect lungs, heart, and trachea. It is located in the mediastinal surface of the lung near the posterior border, and root is formed by the bronchus, pulmonary arteries, pulmonary veins, and pulmonary nerve plexus, lymphatic lymph nodes, areolar tissue, and all enclosed by the mediastinal pleura. Hilum of the lungs is a depression on the medial surface of the lung where the structure of the root enter and exit. And this is the area where the visceral pleura is reflected back to become parietal pleura. There is the extension present of the extension of the mediastinal pleura. This is known as the pulmonary ligament. This fold of peritoneum has some function. It is not true ligament because it is formed by the mediastinal parietal pleura, and it allows for the inferior movement of the lung root with inspiration, and pulmonary vein expansion. Surface marking of the pleura, very important because it is used in many clinical procedure of the thorax. At first, the surface marking of the cervical pleura. First point, the sternoclavicular joint. Second point, at the junction of the medial 1/3 and lateral 2/3 of the clavicle. Third point, above the second point, 2 to 3 centimeter above from the second point. Join this line by a curved line. This is the surface anatomy of the cervical pleura. Now the anterior border. Anterior border of the pleura is different in the right side from the left side. In the right side, the first point is 2 to 3 centimeter above from the right sternoclavicular joint. Second point in the right sternoclavicular joint, not ligament, joint, and third point middle of the sternal angle. Fourth point 6 costal cartilage. Join all these points by a curved line closing the middle of the sternum. The left side, first point 2 to 3 centimeter above the left sternoclavicular joint. Second point, the sternoclavicular joint, left sternoclavicular joint. Third point at the middle of the sternal angle. Fourth point, fourth costal cartilage. Fifth point, sixth costal cartilage. Join this line by a curved line along the middle of the sternum, but fourth and fifth point should make a curve along the lateral border of the sternum. The inferior border. The first point 6 costal cartilage. Second point at the mid clavicular line on the 8th rib. Third point on the 10th rib in the mid axillary line, and fourth point on the 12th rib at the paravertebral line. So this is the pleura. Posterior border, first point on 12th rib near the costovertebral joint, just lateral to the spinous process of the vertebra, and second point, the first rib near the costovertebral joint. Join this line, and this is the posterior border. Pleural surface marking act like a treasure map for the thoracensis. It helps targeting safe zone to avoid lung puncture during needle insertion and guide fluid collection for efficient thoracensis. Pleural recess. Pleural cavity is not completely filled by the lungs, leaving some potential spaces called pleural recess. There are two types of pleural recess is present, costodiaphragmatic and costomediastinal. They allow for full expansion of lung during deep inspiration. They provide a space for fluid accumulation, especially the cardiodiaphragmatic recess. The knowledge of surface anatomy of the pleura and pleural recess is crucial for thoracensis and invasive medical procedure to remove fluid or air from the pleural space for diagnostic or therapeutic purpose. The costodiaphragmatic recess, located between costal pleura and diaphragmatic pleura, it is the largest pleural recess. It forms a girdle surrounding the concavity of the diaphragm against thoracic wall. You see, this is anteriorly the costodiaphragmatic recess, posteriorly costodiaphragmatic recess, and laterally the costodiaphragmatic recess. So this is the most dependent part of the costodiaphragmatic recess, and here fluid is accumulated. Costomediastinal recess lies anteriorly in between costal pleura and mediastinal pleura, and in the left side it is larger due to the cardiac notch. The left costomediastinal recess provides a space for pericardiocentesis done with the minimal risk of injury lungs and other structure. Enlarging this space can make it easier to insert the needle or catheter safely. Due to the large left costomediastinal recess, you can easily approach to the heart without injuring the left lung. The pleura actually descend just below the 12th rib margin at the medial extremity or even below the edge of the 11th rib if the 12th rib is unusually short. In this situation, pleural cavity is lower in position, so it may accidentally expose or incise during exposure of the kidney. Nerve supply of the pleura. The nerve supply of the parietal pleura. Parietal pleura get nerve supply from two sources, intercostal nerves and phrenic nerve. This is the ribs, and ribs contain in the inner surface of the rib contain costal group which contain intercostal nerve, which is the ventral branch of the upper 11 thoracic spinal nerve. They are mixed nerve. They supply intercostal muscle and give sensory supply to the costal pleura and also peripheral part of the diaphragmatic pleura and lateral surface of the cervical pleura. This is phrenic nerve arises from the cervical plexus. Root value is cervical 3, 4, 5. They are descend in between pericardium and mediastinal surface of the lung. During this pathway, it supplies the pericardium, also the mediastinal pleura, and also the central part of the diaphragmatic pleura. It also supplies the medial surface of the cervical pleura. Parietal pleura is sensitive to pain, pressure, temperature, and starch stimuli. Visceral pleura is autonomic supply gets from the pulmonary plexus which is situated at the root of the each lungs. Root of the each lung, it is insensitive to the pain but sensitive to stretch. The component of the pulmonary plexus are sympathetic component is the direct branch from the cardiac plexus and directly from the thoracic 2 to thoracic 6 spinal cord segment. Parasympathetic component arises from vagus nerve which is the 10th cranial nerves. Blood supply and lymphatic drainage of the pleura. Parietal pleura is supplied by the intercostal artery, internal thoracic artery and musculophrenic artery. Visceral pleura is supplied by the bronchial vessels. This is subclavian artery. From subclavian artery, the internal thoracic artery arises and it has terminal branch, superior epigastric artery and musculophrenic artery. So, from this internal thoracic artery, anterior intercostal artery arises. And from musculophrenic artery, anterior intercostal artery, lower anterior intercostal artery arises. So, these arteries supply the mediastinal pleura and diaphragmatic pleura and this intercostal artery, anterior intercostal artery, supply the costal pleura, and this is the arch of the aorta, and posteriorly descending thoracic aorta. From descending thoracic aorta, posterior intercostal artery arises, which supply the posterior part of the costal pleura. Lymphatic drainage of pleura. The parietal pleura is drained into intercostal, mediastinal and diaphragmatic lymph node. Visceral pleura into the bronchopulmonary lymph node near the hilum of the lung. Histology of the pleura. Pleura is formed by the thin layer of connective tissue. This is the thin layer of the connective tissue, and this is the mesothelium, simple squamous epithelium with its basement membrane. So this is the structure of histology structure of the pleura. Mesothelium with its basement membrane and connective tissue. Here only the nucleus of the mesothelium is seen, because cytoplasm is so thin, so it is very difficult to see the cytoplasm of the mesothelium. Development of the pleura. This is trilaminar jump disc. This is primitive stick, primitive node, and from the primitive node, notochord is formed, and due to the formation of the notochord, the surface ectoderm is changed and formed neural plate, and here you see the new cell layer is start to form. This epiblast is converted into ectoderm. This new layer is converted into mesoderm, and the hypoblast is replaced by this cell and converted into endoderm. The mesoderm again divided into three parts: paraxial mesoderm, intermediate mesoderm and lateral plate mesoderm. You see there is a interembryonic coelom is start to appear within the lateral plate mesoderm. One part is run with the ectoderm, and this part of the lateral plate mesoderm is known as the somatopleuric layer of lateral plate mesoderm. One part run with endoderm. This part of lateral plate mesoderm known as the splanchnic mesoderm. So parietal pleura actually develop from the somatopleuric mesoderm, and visceral pleura is developed from the splanchnic mesoderm. This is the derivative of the development of the pleura. Now the gradual formations of the pleura. So this is interembryonic coelom. This is the single cut section of the interembryonic coelom. But how interembryonic coelom is located in the trilaminar jump disc? It is located like this. It is a U-shaped structure situated in front of the cranial end and two sides of the neural plate. So this U-shaped area again divided into this part is from future pericardium, these two part from future pleura, and these two part from future peritoneal cavity. So what happened? The connection between the pericardium and future pleural sac, there is a two membrane is present: pericardio-pleural opening and pleuro-peritoneal opening. These two opening is replaced by pericardio-pleural membrane and pleuro-peritoneal membrane. So there is the connection between pleural cavity and peritoneal cavity is lost. The connection between pericardial cavity and pleural cavity loss. This is the invagination of the endoderm. This is the primitive gut. This is foregut, midgut, hindgut. From foregut, the lung bud is start to grow. You see, lung bud is start to grow and it's run toward the future pleural cavity. Two membrane is already formed and lung buds start to grow toward the future pleural cavity. So lung bud is press the pleural cavity like this. So the part of the pleural cavity attached with the lungs known as the visceral pleura. The part of the pleura is away from the lung is converted into parietal pleura. And these two end is the pleuroperitoneal membrane and pericardio-peritoneal membrane. So like this, lung bud is pushed toward the future pleural cavity, and this is the ultimate adult structure. Radiology of the pleura. Sonographic feature of the pleura. Pleura appear as a bright moving line on the lung sonography. Pleura always appear as a light, bright line. And thickness of the pleura can be measured in sonographically, and when the thickness is greater than the 3 mm, it is considered as a pleural thickening. This is ultrasonography probe and it's placed in between two ribs, and so this is the two ribs and this is the intercostal space, this is the intercostal space with its muscle, and this is the bright line indicate pleura, and this is black shadow is for lung. So this is the pleura, this is the pleura. Intercostal muscle, intercostal muscle. Clinical anatomy. Pleural effusion. Pleural effusion means abnormal fluid collection within the pleural cavity. You see, in the normal chest X-ray, the costodiaphragmatic recess is sharp, acute and 30 degree, and it's easily seen. But in pleural effusion, this angle is lost, difficult to see. In the MRI scan, this is the pleural effusion behind the lung shadow. Hydropneumothorax. When pleural effusion and pneumothorax is present, then this condition known as the hydropneumothorax. Pneumothorax means air within the pleural cavity. So this is pleural effusion, it's make a curved line, and hydropneumothorax is create a straight line. This is for air, this is for fluid. Thoracentesis. It is a procedure to remove excess fluid or air from the pleural space between lung and chest wall. It can be done for both diagnostic and therapeutic purpose. Needle should be entered just above upper border of the rib to avoid injury of the neurovascular bundle present in the costal group. To ensure a sufficient fluid collection and minimize risks of injuring the diaphragm, it is typically performed posteriorly or laterally. Fluid collection is done from the posteriorly and laterally because you see this is the most dependent part of the costodiaphragmatic recess. So fluid accumulation is occur here. So fluid collected from here. The common space to collect fluid is the 7 or 8 intercostal space, and usually it is done 1 to 2 intercostal space below the highest level of pleural effusion. Sonographically determine the level of fluid and fluid collected from 1 or 2 intercostal space below the highest level of pleural effusion. Too much lowering, um, we don't enter needle in the lower intercostal space to avoid injury of the abdominal organ. You see, kidney is situated here, liver is here, and lung is here. Pneumothorax is the air within the thorax, and it um, air within the pleural cavity, and its push press the lung, and lung huge collection of the pleural effusion collapse the lung and shift the mediastinal structure opposite the opposite direction. Air usually accommodated in the upper surface of the pleural cavity. So the air is withdrawn from the second intercostal space in the mid-clavicular line. And this is the collapsed lung. In chest X-ray, this collapsed lung shadow the line of collapsed line shadow, and the air containing area also seen. This air containing area is look more black than the other part of the chest X-ray. So you see, this is the collapsed lungs, and this is the collapsed line, and this is the pleural. This is the pneumothorax. So you see the chest X-ray, normal chest X-ray. This is highlight shadow, and you see here this is more black than the normal lungs. The diaphragmatic margin may not visible in the affected site due to the air in the pleural space. The mediastinal shift opposite the presence of the pneumothorax is present in this site, and trachea shift opposite site. And there is a lack of lung markings. This lung marking is difficult to see, and you see, due to the pneumothorax air presence, this part is more black than this part. Empyema. Accumulation of the purulent fluid in the pleural space, often due to the pneumonia or trauma. The border between lung fluid and lungs is often irregular and loculated rather than smooth. Pleurisy means inflammation of the pleural membrane, and it cause of this pleurisy: infection, autoimmune disease, malignancy, and symptom is fever, chest pain that aggravate with breathing due to the irritation of the intercostal nerve which supply costal pleura and the peripheral part of the diaphragmatic pleura. Sometimes it may radiate to the shoulder if the mediastinal and diaphragmatic pleura is involved. The phrenic nerve originates in the neck, in the cervical 3, 4, 5, and it is a mixed nerve, both has motor and sensory part. It supplies the mediastinal pleura and central part of the diaphragmatic pleura. So irritation of the mediastinal pleura or diaphragmatic pleura causes referred pain radiated in the shoulder area, because dermatome of the shoulders is cervical 3, 4, 5. So the pain of the pleura is misinterpreted in the shoulder, affected side of the shoulder. Based on this knowledge, there is a clinical question. A 45 years old male patient present in the emergency department with complaint of sharp chest pain that worsens with breathing. He also reported a recent episode of fever. Upon examination, pain is noted to be exacerbated by deep inspiration. The patient mentioned that the pain sometimes radiated to his shoulder. Considering this information, answer the following question. What is the most likely diagnosis based on the following presentation? Why in this condition chest pains increase during breathing? Why this pain sometimes radiate to the shoulder? Explain anatomical basics of it. So answer of the first question is most likely diagnosis for the pleurisy or pleuritis. His symptom of severe chest pain that worsens with breathing along with fever suggests inflammation of the pleural membrane characteristic of the pleurisy. What is this condition chest pain increase during breathing? In pleurisy, chest pain increase during breathing because the inflammatory pleural membrane rub against each other with each breathing. This friction is particularly painful due to the involvement of the intercostal nerve which supply the costal pleura. During inspiration, the lung expand, causing the pleura to stretch and move, which aggravate the pain. The patient's chest pain radiates to the shoulder due to the involvement of the pleural membrane, especially the mediastinal and central part of the diaphragmatic pleura, which is innervated by the phrenic nerve, which originated from the cervical T to cervical 5 spinal nerve. Phrenic nerve also provides sensory innervation to the shoulder area. When this pleural area is irritated, the pain is referred to the shoulder because base misinterpret the origin of the pain signal thinking they are coming from the shoulder instead of pleura. So this is all about anatomy of the pleura. If you find this video helpful, please subscribe my channel. Please. Thank you for watching.